So my name is Tracy Glenn, and I'm with the Canadian Health Coalition, and it's my pleasure to introduce, well, a couple people that I get to work with. Two issues that the Canadian Health Coalition cares about is migrant health care as well as reproductive health care, and so I get to work with Chen, and who's going to be speaking on revisiting the waiting period allowance under the Canada Health Act. We also have Martha Paynter with us, and she's going to be speaking on barriers to abortion without barring abortion, addressing private costs and family planning care. And then we also have Marie Carpentier, who is with the Université du Québec, Montréal, who's going to be speaking about the international law and how it can come to the rescue of the Canada Health Act. So I'm going to turn it over to YY.
Hi, everyone. Hi. So my presentation today will invite us to rethink about this allowance under the Canada Health Act for provincial and territorial health insurance programs to impose a waiting period before healthcare coverage takes effect. Right. So ultimately, I'm going to put my conclusion up forward and just say that I argue that especially for Canadians are returning from a prolonged stay abroad, as well as newcomers settling in Canada, these kind of waiting periods threaten their health and well-being and serve a legislative objective that I think is somewhat dubious. And as such, waiting periods, I argue, should no longer be allowed. So the allowance that I'm speaking of is contained in Section 11(1)(a) of the Canada Health Act. This provision states that in order to satisfy the portability criterion, provincial and territorial health insurance programs must not impose any waiting period longer than 3 months before their respective residents are eligible or entitled to insured health services. In other words, the portability criterion permits provincial and territorial health insurance programs to put in place a waiting period so long as the length is not longer than 3 months. This allowance is then buttressed by Section 2 of the Act, which then defines insured persons as excluding residents that have not fulfilled the waiting period. Today, all provinces and territories in Canada have taken full advantage of this waiting period allowance by imposing a 3-month waiting period on people moving to their jurisdiction from another jurisdiction within Canada. So all provinces and territories do that for people moving within Canada. Now, that typically doesn't pose too much of a problem for people because provinces and territories have also put in place corresponding rules such that they will continue to cover, provide healthcare coverage to people up to 3 months following their leaving of the old jurisdiction. And for that reason, right, the focus of my talk, as I mentioned at the beginning today, is really going to focus on how the waiting period affects people that come to Canada from outside of the country, right? So again, these include returning Canadians as well as newcomers to the country. And for these populations, provincial and territorial policies concerning waiting periods vary quite a bit. And so here I provide you with a table. At the very top, you will see that just over half of the provinces and territories do not impose any waiting period on new residents coming to their jurisdiction from abroad. Right, so these include Newfoundland and Labrador, PEI, Ontario, Manitoba, Saskatchewan, Alberta, and Nunavut. Okay. What's notable on this among these group of provinces is the absence of a waiting period in Ontario. Okay, this is actually a relatively recent change. It was a policy change introduced in early days of the COVID-19 pandemic to facilitate people's access to necessary healthcare. As the threat of COVID-19 starts to fall off, government's priorities, Ontario has since walked back on a number of pandemic measures. So I think it will be really interesting for us to kind of keep an eye on this and to see whether or not Ontario Health Insurance Plan going forward will continue to impose no waiting period. Now, in the boxes that are shaded in yellow, you see that another 5 provinces and territories currently impose no waiting period on some people coming from abroad, but then not for others. For instance, in Nova Scotia, returning Canadians as well as permanent residents and eligible migrant workers moving from abroad will have their healthcare coverage from the first day that they arrive in the province. However, if you're an eligible international student in the province, you will only qualify for provincial health insurance after up to 13 months of wait. And at first glance, this long residency requirement would seem to contravene the portability criterion under the Canada Health Act, which, as I mentioned, says that a waiting period cannot be longer than 3 months. Right? And then looking at another province within this group, another standout is Quebec. So Quebec delineates waiting requirements based on not only population groups, but also on the type of health services that are provided. So even for new residents who would normally be required to sit through an up to 3 months waiting period, there's no wait if they're seeking services relating to pregnancy, childbirth, or termination of pregnancy, or treatment for infectious diseases that have public health impact, and as well as support for victims of sexual assault and intimate partner violence. And now if we move down to the very bottom of this table, we see that British Columbia is the only province that requires all residents coming from abroad to undergo an up to 3 months waiting period. Although there is an appeal process in place to obtain a waiver of this waiting period, these requests are approved only in the most extenuating circumstances. Studies have shown that the 3 months waiting period threatens people's health and well-being. So individuals required to wait often delay medically necessary treatment in order to avoid out-of-pocket expenses. And that delay in treatment can cause serious harm to people's health. And for those people who are unable to wait, well, then they are frequently left with significant medical debt. Right, so on the slide is an example. So this is from a study done by Ritika Goel and her colleagues on the effects of Ontario's former 3 months waiting period requirement. Right, and they described interviewing this newcomer woman who incurred a hospital bill of over $12,000 after going into labor during the waiting period. And so this newcomer lamented, and I quote, "The hospital and the charges, it's a whole lot of money. Right? The person just comes to the country, you haven't settled yet, you haven't got a job yet, and then you're started by having bad credit, owing everywhere. Right? They create a world of debt, which one cannot imagine, and that to me, for an immigrant, is disastrous." And so the hardship facing people during the waiting period actually is not unknown to provincial and territorial governments. And in fact, I was talking to my co-panelist, Marie, earlier today, who informed me that back in 2013, Quebec's Human Rights Commission actually penned a report on this very subject that concluded the 3 months waiting period is a breach of people's right to security, integrity, and dignity that are protected under Quebec's Charter of Human Rights and Freedoms. Be that as he may, right, to mitigate the harms or potential harms of the 3 months waiting period and the possible rights breaches, many provinces and territories that impose such a waiting period actively encourage new residents to take out private health insurance. And so on the slide is one such example that I just take from the BC government's official website. Now, of course, not everybody can afford the premium for private health insurance. And also, as you've seen, acknowledged by the BC government itself, private health insurers don't cover everything. It often do not cover the cost of pre-existing health conditions, including pregnancy. And so the suggestion that new residents could simply purchase private health insurance during the waiting period, I argue, raises serious equity concerns. And so in light of these problems, you might be asking also, why do some provinces and territories continue to impose a waiting requirement? The rationale appears to be twofold: cost saving and deterrence against health tourism. Okay, so as a case in point, when Ontario introduced its former 3 months waiting period back in 1994, then Health Minister Ruth Greer claimed that the measure would save Ontarians about $18 million per year, and it would prevent people from coming to Ontario for the sole purpose of receiving health care and then just leave again. Both of those rationales, however, I argue, it's somewhat suspicious. I think, with respect to health tourism, there's currently no concrete evidence that suggests that this is of any kind of significant concern in Canada. And that lack of empirical evidence, I think it's not surprising, given that in order for a person to qualify for Medicare, you already have to have certain citizenship and immigration status to begin with, and that you need to show some proof of residency. And so even without a 3 months waiting period, there is simply no way, right, for a tourist with no connections to Canada previously to come to the country and then get healthcare free of charge without having first gone through the arduous process of obtaining permanent residency or some kind of immigration documents such as work permits or study permits. And so it follows that any expectation of significant cost saving that will result from this deterrence against health tourism, again, is questionable. Now, even if there is a cost saving to be had, surely that must be weighed against the bodily and financial harms that we know face people who are subject to the waiting period. Right? To the extent that these harms undermine people's health, we know that, well, the government at the end of the day will still have to pick up the cost associated with that healthcare, or that harm to people's health, right? Because at the end of the day, people just need to wait 3 months and then they will get healthcare. And so any kind of saving is really not truly a saving, but just deferred cost. So for all those reasons, again, I suggest it's perhaps time for us to rethink about this allowance under Canada Health Act, and perhaps to think about, at least for people coming to Canada from outside of the country, this permission of a 3 months wait perhaps is contrary to our very belief about what is just. And it just doesn't make policy sense at the very bottom line. Okay, thank you.
Thank you, YY. I realized that I didn't properly introduce the speakers. I just said your titles, but or what you were speaking to, but just, yeah, I think many of you know YY Chen is here at the University of Ottawa's Faculty of Law. And just going next to Martha Paynter, is the Director of Nursing Research with the Contraception and Abortion Research Team at UBC and is an Assistant Professor at the University of New Brunswick's Faculty of Nursing. So take it away, Martha. How's the volume? Good, no, more?
How's that? That sounds better. No image though, eh? Well, I'll just begin. I'd like to begin my presentations with a land acknowledgement that I work on the land of the Wolastoqey in New Brunswick. And I also want to come back, if I ever get this to work, to the issues about New Brunswick that Jennifer and Lee raised earlier this morning. And I think that there's a lot of confusion about the place of abortion in New Brunswick that can be remedied pretty quickly. I just wanted to comment, since I have a second, my deep appreciation of Professor Chen's presentation as an abortion care provider in Nova Scotia, where there is that 13-month wait for international students. I've certainly had to deal with desperate students who need to find $2,000 in cash to have care, regardless of whether they choose procedural abortion or medication abortion. The cost is really quite high. And it really, the other piece that you brought up, and it's the first time today that gender analysis has been brought up, and it's incredibly important in so many domains, from home care to mental health to, of course, what Chen raised about the uniqueness of pregnancy as a pre-existing condition. And the it's funny, but it's also in our ability to control pregnancy is fundamental to our democracy and our participation in civil society. So the meaning is very, very big. All right, I'll get on with this. So in my work, I collaborate with an artist out east. Her name is Julia Hutt, so I give her credit for all of these illustrations. What I wanted to talk about, because we're in this post-Dobbs decision, chaos, despair time, is actually how much progress we have made in the realm of abortion in this country in the past 10 years. It is extraordinary. Our realm from 1988 was unique in the world as the only jurisdiction with complete decriminalization, and we have made massive strides since 2015. These go underappreciated. Nobody writes about good news. So to my journalist friends, please start writing about some good news, because we have so much of it. So prior to 2015, we were in this period. Of course, we had the therapeutic abortion committees from 69 from the omnibus bill to 88, the Morgentaler decisions, when a person seeking an abortion had to appear before a 3-person physician committee and beg for their approval that her need for an abortion merited their determination that her health was at risk otherwise. These therapeutic abortion committees were not mandatory. The hospital didn't have to have one. And the Bagley committee found that in the 70s, a third of hospitals in Canada didn't even have 4 physicians, let alone 3 that were keen to say yes to this. So that ended in 88. We had the charter, we had CHA, we had the Morgentaler decision in 1988. But then, for the 88 to 2015 period, we had a lot of stasis. For that whole time, abortion remained the domain of physicians. Only physicians were authorized to perform them. And 96% of them were procedural. You had to go into a clinic or a hospital-based clinic to have the procedure, despite medication abortion being approved in France in 1988. And we also, of course, had providers clustered in major urban centers and massive travel requirements for patients. Revolution. 2015, Health Canada approves mifepristone. I'm sure Dr. Lutchkin could speak to why it took decades of delay for them to get around to it, but they did. Yeah. Yeah, they were, anyway, that's another discussion. They did do it though. Okay, so that ushered in a whole new era. When we first had MIFI, there were a whole bunch of regulations, many of them borrowed from the Australian context, that restricted use of the medication. So basically, it was only physicians who were already doing procedural abortion anyway who would end up prescribing. One by one, all of these regulations fell away. And Health Canada completely deregulated mifepristone. It is the same as every other medication. There is no special requirement. And of course, nurse practitioners can prescribe it. So suddenly, the physician-only domain of abortion exploded to include nurse practitioners and the nurse practitioner way of practice, and potentially the privatization in nurse practitioner practice. We also had, starting with New Brunswick, public funding for mifepristone. Here is a pill that you take at your house that the government pays for. You present your Medicare card at your community pharmacy and you go home. Also, we have COVID. COVID ushers in a huge wave of virtual care. We all know this, but imagine how important this was for abortion. Now, you don't leave your house at all. You call, you have a consultation over the phone with your prescriber. As long as you meet certain criteria clinically, and I'll get into that maybe, if you care, you can have that prescription with no blood work, no ultrasound. You don't leave your house. You have to go to the pharmacy. Maybe the pharmacy can send it to you in a taxi. This totally changes the experience of abortion. It is private. It is convenient. It is easy. It doesn't cost any time. Doesn't cost any money. Did you all realize that had happened to abortion in 2015 to 2017? So we also see in the past 10 or so years, massive scope expansion. This was alluded to earlier. We see nurse practitioners prescribing mifepristone. We see registered midwives, in theory, able to prescribe mifepristone in Quebec. There is an Ontario pilot where they're doing that as well. We see pharmacists prescribing of birth control happening in 8 provinces. Nurses, registered nurses, are prescribing contraception in several provinces. So we see all of this ability to give this care expanding, and to people who are not necessarily fee-for-service. So they can have these very extensive conversations with you to make sure that you're getting the contraception that meets your needs. We also have, because during COVID, we realized our reliance, and we relied heavily on the US for later gestational duration care. Our reliance on that care was not good. Our patients did not have vaccines. They did not have the ability to get to Colorado during COVID. And that reliance that we had had for decades, basically since Roe in '73, was not working for us anymore. And so across the country, one by one, providers everywhere improved their skills and started offering later care. There is no limit in law to gestational duration in Canada. And we now have capacity improved pretty much everywhere. And we have all gestational duration care here in Ontario. Now, the problem that remains is that we don't train anybody to do any of this. So they have to figure out how to do this. We haven't caught up in terms of our health professional curricula, but we're working on it. And another problem that we need to keep in mind, and how this influences everything, is the potential de-skilling. When you have massive expansion of mifepristone, of medication abortion, way fewer people are doing procedural abortion, which you will always still need. And if you aren't doing enough of something, you will no longer be competent. And we've seen in countries like Scotland, Sweden, where medication abortion is 95, 99%, they are simply not able to offer this care anymore in the odd chance when you really need it. So we need to be cognizant of that. We also, of course, universal contraception in BC. And, this proceeded in a stepwise progression. My team at the Contraception and Abortion Research Team out of UBC have done tons of research throughout this process. We started with free contraception for people post-abortion. Obviously, that makes sense. These are people who are obviously fertile and they obviously experience contraceptive failure. Great place to start. And then we see it expand. At every step in the way, this is an extraordinarily sound investment. The returns on preventing people from having unintended pregnancies turn into unintended kids are enormous. You are preventing people from being stuck in violent relationships, which is probably the #1 reason why people come to us for care. Not that we ask for reasons. You are preventing people from leaving school, leaving their employment goals, and they are able to have kids when they want. So we've seen how the uptake for this has been extraordinary in BC, 1 year in. And we've already talked about the joint announcement, the Valentine, so we'll let that go. So this all sounds incredible, and I hope you feel good, okay? What happened in the US, the Dobbs decision, that was real bad. But what we have been doing is really good, and it deserves to be known and celebrated. However, we have also been experiencing ramping, increasing austerity. And so what does it matter if you have medication to have your miscarriage at home if you do not have a home? We really need to be thinking about the broader socioeconomic life of the abortion patient when we are thinking about what are we worried about in terms of the violations of the Canada Health Act in this domain of care. And really rethinking from that frame of reproductive justice. Reproductive justice is a movement, a philosophy that grew out of Black American feminism. It was coined in the 90s, but it theoretically has gone on forever in terms of Black feminist thought. And this really critiques a white feminist obsession with abortion to say not only do we need the right to not have a child, but the right to have a child and to parent that child in safety and security, in a good world, in a safe home. So when we take that reproductive justice lens and look at what's been happening in these years where we are just trumpeting our accomplishments in abortion, but look at what people are living, right? Poverty's flying up, food insecurity's flying up, incomes are going down. And as Dr. Chen was speaking about, we have these uninsured people. For example, between 2000 and 2021, look at what happened to the number of temporary foreign workers who are inadequately insured. And for everyone, but definitely for those temporary foreign workers who are women, they are extremely vulnerable to sexual exploitation. They need this care available without question. International students, 2022, we got 1 million of them. And they are an afterthought. Even if, say it's not Nova Scotia, say it's not the place where you have to wait for 13 months as an international student, what if the international student coverage that you're given for just the 3-month period, what if that won't cover your abortion? Maybe it's because pregnancy is a pre-existing condition. Maybe it's because you're from a country where you are not allowed to have one. And that comes with you. So we see also, this is the stuff that we've talked about, right? So, Sarah alluded to this, right? When you have private ultrasonography clinics, 3D baby, and so on, who is staffing the actual ultrasounds that we need to ensure that our pregnancies are healthy? Yeah. Honestly, this is a big thing. What about public transit? So in New Brunswick, we have 3 abortion clinics. They are located in hospitals. They are staffed by extraordinarily dedicated family planning professionals. They are in Moncton, and Bathurst. We also have a huge number of nurse practitioners, family doctors, and obstetricians and gynecologists scattered everywhere who are prescribing medication abortion. Medication abortion is 2/3 of abortion in New Brunswick. Just think about that. We've only had it since 2017. Okay, so in this province, yes, we had a freestanding private clinic that closed, but we have other clinics and we have other types of care. So we need to focus on what's the actual problem. The problem is there's no bus to Moncton. That's the problem. Can we get a bus to Moncton? So where do we go from here? Obviously, universal contraception for all, not fill in the gaps, completely universal, completely. No 14-year-old needs to apply for anything on her own. No, thank you. And we also need to really wise up to the incredibly anomalous and fantastic position of abortion in Canada, in the world. And then we need to put more energy into those deeper reproductive justice conversations and problems so that people can have their abortion, but they can have their happy, healthy family too. Here's my contact. I do have a couple of my books at the back, and I'm happy to talk at the break.
Thank you, Martha. So we're gonna, turn it over to Marie Carpentier, who, as I mentioned, is from UQAM and has also been the legal counsel for the Commission des droits de la personne et des droits de la jeunesse. So hopefully you'll get your slides up.
So it's the last one.
Yep.
And I want to state before beginning, I'm the real Marie Carpentier, not her.
I think these are right, not that you can read them.
So, good, thank you. So good afternoon, everyone. I'd like to thank the organizers for having me today. So the presentation is in French, but I'll speak in English since I don't trust too much AI. So I'll do my own translation. I'm very glad to have the opportunity to share some thoughts about the possibility to adduce international law in support to the interpretation to the CHA. I postulate that contrary to the popular and judicial belief, this possibility already exists and should be used more thoroughly. These reflections are a very small part of the thesis that I defended with success last August about the democratic legitimacy of the right to health, of the justiciability of the right to health in Canada. I'm very proud to say it has been accepted for publication, so you can read it in French some forward day. Since I don't have much time today, I'd like to focus on one single idea. And okay. International law, especially but not limited to treaties signed by Canada, can be used to interpret both constitutional and ordinary, meaning non-constitutional laws, such as the CHA Act. Allow me to explain. In 2018, the United Nations Special Rapporteur on Right of Everyone to the Enjoyment of the Highest Attainable Standard of Physical and Mental Health visited Canada. It is part of his mission to visit state members of the United Nations. He produced his report to the Human Rights Council in June of 2019. He made remarks on topics requiring some additional work from Canada to comply with its obligations regarding the right to health such as mental health, indigenous people, or other groups of vulnerable situation in vulnerable situation, and sexual and reproductive health. I have some issues. Oh, I am trying to do some interesting stuff. I don't know how to how to switch a slide. Ah, there. No. Okay, thank you. Okay, thank you. Thank you. So the special rapporteur made a specific observation regarding what we call domestic reception of international law in Canada. He says, I quote, the special rapporteur received information indicating that a common opposing argument to such judicial challenges is the inaccurate assumption that the international human rights obligations of Canada have allegedly no binding legal effects. He stresses that international human rights law presents obligations that states are bound to respect when they become parties to treaties. So the judicial challenges he is talking about are, among others, the ones in which charter rights, such as the right to life and equality rights, are used as proxies to the right to health. Basically, tribunals refuse to recognize even the interpretative value of international law in those circumstances. The rapporteur made some recommendations accordingly to help Canada comply with its international obligations. One, to include human rights criteria in the existing criteria for health federal transfers under the CHA, and consider adopting a right-based national healthcare framework strategy for the whole country. So, the advantages linked to the health-based approach to include an health-based approach in the CHA is, amongst other, non-discrimination, acceptability, quality, well-focused or educated consent. And I would add also the non-regression clause that exists in international law. That means that when we reach a certain point in the realization of the right to health, we should not go back afterwards. So this is entrenched in many international law sources. So these are, the right to health does not appear as such anywhere in Canadian law. So we don't find it anywhere in our laws in Canada. It is nonetheless guaranteed by many treaties signed by Canada, such as the World Health Organization Constitution, which is an old one in 1946, I guess. And also the International Covenant on Economic, Social, and Cultural Rights, and in many thematic treaties, such as those regarding the rights of women or the rights of children. You have the list there. Regarding domestic reception of international law, Canada is what we call a dualist jurisdiction, meaning that signed treaties don't become national law automatically. They have to be transformed by a legislative act to be considered as binding. They can also be implemented, but I spare you the details on this complicated matter. Treaties not being transformed or implemented doesn't mean they don't produce any effect. And this is exactly the point I want to make today. Courts in Canada admit that signed treaties, and even to a certain point unsigned treaties, must produce their effect in the Canadian law by the means of the presumption of conformity. According to the Supreme Court, and I quote, it is a well-established principle of statutory interpretation that legislation will be presumed to conform to international law. The presumption of conformity is based on the rule of judicial policy that, as a matter of law, courts will strive to avoid construction of domestic law pursuant to which the state would be in violation of its international obligations unless the wording of the statute clearly compels that result. This presumption is oftentimes invoked in the context of charter rights interpretation. The Supreme Court this court has explained that presumption of conformity operates principally as an interpretative tool in assisting the courts in delineating the breadth and scope of charter's right, but it can also be used as a way to interpret ordinary laws, as the CHA is considered an ordinary law, a non-constitutional law. So this can be this is most important for the interpretation of the CHA Act, since so many treaties has been signed that protect the right to health. Another convincing argument of the value of international law in the interpretation of the CHA is the way Canada uses this statute as a proof of its realization of the right to health. Indeed, Canada must periodically report to international instances to explain the measures it puts into place to realize the rights included in the treaties he had signed. As it states in the 4th report regarding the International Covenant on Economic, Social, and Cultural Rights, Canada realizes the rights included in the covenant by the means of its law and politics. It also specifically refers to the CHA as a way to promote and respect the right to health. It is my opinion that this fact should support the possibility for judicial instances to refer to the covenant and other source of international law when interpreting the Canadian health law. To conclude my presentation, I'd like to say a few words about the Toussaint case. Some of you must know. The Canadian Health Coalition intervenes in this case. As an irregular immigrant, Nell Toussaint was denied access to essential health services in Ontario. All our judicial demands were dismissed, so she took her grievances to the United Nations Human Rights Committee. Note that this committee bears some responsibility in the administration of the International Covenant on Civil and Political Rights, and does not encompass the right to health as such. But in 2018, the committee concluded that in refusing her access to health care, Canada had violated Toussaint's rights to health, to life, and her equality rights. It directed Canada to provide Ms. Toussaint with compensation and to take positive steps to fix healthcare legislation so that others in similar situations would have their rights to healthcare protected. Canada refused to implement the views of the committee. So with the help of her courageous, this is my qualification, attorneys, she is suing again. In a decision regarding a preliminary motion to strike, the Ontario Court of Justice has decided that the case raises the novel question of the relationship among the enforcement of human rights guarantees of the Canadian Charter of Rights and Freedom, the enforcement of human rights obligation under Canada's treaty obligations, and the enforcement of human rights obligation under customary laws. It is my view that this decision to come, so the process is in course, will have also an impact on the interpretation of the CHA. Thank you very much for your listening.
Thank you, Marie. I'm really glad that you ended with someone who has inspired many of us to fight for universal healthcare in El Toussaint. So we have a few minutes left for questions. Okay, Marc-Andre.
Thank you. Well, thank you to the three of you for the great presentations. Question, well, comment for Martha is just, you finished by saying we need universal contraception nationwide. So just going back to C64 about the debate about what do we mean by universality? If we define universality with everybody should be getting coverage, be it public or private, and the thing is, if you start with mandatory private coverage, I mean, there's a world of a difference for teenagers or young adult to be, if my coverage comes through my parents' employers, basically I need to ask authorization, permission to have access to the reimbursement for contraception, which is absolutely not the case if we have a real universal system where basically it's your right from the start to get access. So just universal contraception, yes, but the definition of universal is what is important here in C64. So thank you.
Yeah, the model would be exactly as we've done with mifepristone. And in fact, mifepristone is this incredible model to just look to, that you present your health card and you get the medication and everybody gets it paid for by their provincial government. The end. Yeah, this is going to cost a fortune, but like it will, the returns will be there. And it's very clear that the patchwork system especially does not work with birth control. It's way too, it should not be, way too much shame, way too much stigma, way too much parental control. And now we're in this terrifying wave of parental rights. No, thank you. So the Medicare card model, plus no waiting for a Medicare card, right?
Any more questions, or maybe the panelists want to respond to? Oh, okay. Oh, Sarah.
Thanks very much. Merci beaucoup, Marie. C'était super intéressant. My question's about the federal government's reluctance to recognize the recommendations of the UN Human Rights Commission, and what you think politically is motivated, because it isn't just one government, it's a succession of governments over many years that have failed to meaningfully take these recommendations on board and translate recommendations into legislative action. So I was wondering if in your research you've looked at what those roadblocks are for domestic implementation of human rights law in Canada.
Thank you. I looked at the reluctance of the tribunals, not the political reluctance. And for the tribunal, there's the as you know, health right, the right to health is a socioeconomic right. So it's kind of difficult for the tribunals. This is the subject of my thesis. It is kind of difficult to, they have a safe exit saying they don't want to overcome their power if you think of separation of power. So they say it's not the role of tribunals to decide a question of healthcare. So what I'm trying to do, what I'm thinking, it's tribunals have a responsibility, I'd say, just to have a look to see if the decisions, and this is my point, are reasonable. So they don't have to decide what's good, what should be covered or not covered. I don't think it's the role of the judicial to decide of this. But I think there's so much money put into health from us, from the taxpayers, and in pharmaceutical produce. I learned so much about some money we are paying for the public insurance and all. I think the judicial power have at least a little duty to see if the decisions that are made are educated and reasonable, and what are the interests they do take into account when they are deciding. So this is my view to the point, but I don't know. Maybe it would have too much consequences for the government of Canada to accept the decision of the committee. I don't know.
Wait, on that point, can I just add something? So for disclosure, so I'm actually one of the co-counsels representing the Canadian Health Coalition and others intervening in the Toussaint case. So when it comes to the government's refusal in this particular case, I think some of the rhetoric that we heard from the government has been that it touches on something that I've talked about earlier about health tourism, right? This idea that somehow if we grant healthcare to irregular migrants, the government frame it as a right to healthcare for everybody in the world. So essentially anybody can come to Canada and just get healthcare and leave. And that has been one of the arguments that just kept coming up from the government as a reason why they, first of all, disagree with the Human Rights Committee's interpretation of the international law, even though the Human Rights Committee is considered the expert in interpreting that law. And that, it just wouldn't implement the recommendation. So at least on this particular issue, I think, the fear of health tourism coupled with, like very prevailing sentiment of anti-immigrant feelings in society, I think that together, at least on this particular issue, is something that I don't see the government just gonna budge in anytime soon.
Dan?
This is a question for YY. One of the other active issues right now was the government's prior commitment around regularization. And I know this is a contentious issue right now. The Minister of Immigration, Mark Miller, has kind of made some wishy-washy comments about whether or not the federal government will fulfill its promise to regularize people who were previously undocumented. And I'm wondering, like, how does that would in part, by regularizing them, it would give them access to the same like public health insurance that those of us with status have. How does the issue that you're dealing with fit into this larger issue, and how would regularization change some of the other legal challenges you're involved in?
So when it comes to regularization, I think there's, obviously, and again, I'm going to state my personal position. I'm obviously in favor of regularization, right? Like, I don't think anybody should be put in a position where they're living in a country without any kind of legal status. That puts them in a very precarious situation, both in terms of their personal lives, but also all other aspects of their life, whether it's employment and so on and so forth. So I'm all for regularization. And I think to some extent, regularization will address some of the concerns that I raise. But I think the 3 months waiting period issue that I'm raising, it's related, but somewhat different, right? I'm talking about people who move to the country, right? That, I guess the waiting period comes up during that initial period. So that covers some people that might be without status from the get-go. But we know that in Canada, most people fall out of status rather than being without status from the very beginning. So there are very few people who come to Canada are, who are irregular from the start, right? They usually come with some kind of documentation, and then they become non-status afterwards. And so I'm not sure if regularization in that, even this particular Canadian context, will solve the waiting list or the waiting period issue that what I was referring to. But again, I'm all for it, and I think it will definitely help. Again, but then regularization is only kind of a cross-sectional approach, right? It's one time you kind of resolve that issue, but then what happened to people who are irregular and who come afterwards, right? You're still not dealing with the root cause, which is ensuring that people will have access to healthcare irrespective of their immigration status.
Okay, we'll take one more question from Pauline.
It's a two-part. First of all, I wanted to thank Marie for mentioning the Nell Toussaint case. Second of all, thank you for your work on co-counsel in collaboration with Canadian Health Coalition as intervener. But I would like Tracy, maybe you could tell Nell Toussaint's story or why to the group, because I'm not sure everybody here knows the story. And she's a real activist, or was a real activist and advocate for immigrants and healthcare in Canada. So I'd like you to briefly share the story, please, and thanks.
All right, so I'll give it a try. So Nell, as mentioned, unfortunately passed away last January. But so she came to Canada in 1999 when she was in her late 30s, early 40s. She came from Grenada. As I mentioned, like most people in this situation, she came first as a visitor because she had worked in Grenada and heard that Canada was a good place. So she came, and then when she was here, she happened to find work. So she decided to stay even after her visa had expired. So for about a decade, she was able to work under the table and sustain her own daily life. Even we have some evidence and record that shows that from time to time she actually pay into the various government programs such as EI and so forth, because we have pay stubs that shows that employers are taking money away from the salaries, right, to pay for those government programs, just going at the myth that these people don't pay into our taxes. But then unfortunately around 2008, she started to develop a series of health conditions. Chief among them is just long-term untreated diabetes, hypertension, and then she had also had strokes from multiple times. And unfortunately, she tried to apply for Ontario Health Insurance. Because of her status, she didn't receive any coverage. And then so she applied to what's known as the Interim Federal Health Program, which is a federal government-run program that's typically meant for refugees and refugee claimants. Now, because she is an irregular migrant rather than refugee claimant, she was also denied coverage under Interim Federal Health Program. So essentially, what she was left with was charitable care that she was able to kind of get from time to time, right? Some hospitals able to, some doctors were willing to treat her from time to time, but it was by no means adequate. And so, again, there was evidence before courts that showed that by 2009-ish, that her treating doctor at that time said, unless she had proper healthcare coverage, that her life is seriously in danger. And that, again, because of that background, that prompted the case that Marie was referring to. She essentially sued the federal government for the decision to deny her coverage under the Interim Federal Health Program. And unfortunately, our Federal Court of Appeal both said there's no charter violation in this particular instance because she was, essentially any kind of harm that she suffered is her own doing by choosing to be an irregular migrant in this country. And that's when she decided to, with the support of her team, to take her case to the United Nations Human Rights Committee. Right. And so through this process, we talk about the courage and the courage that she had, because as an irregular migrant, she was risking deportation, right, along the way. And anybody who's seen her knows that because of diabetes, she had to have one of her legs amputated. She was essentially traveling using wheelchair, and she couldn't really speak because of the brain aneurysm that she suffered. So she was really having trouble. But through all that, she still wanted to do court challenges because she believed that she doesn't want anyone else to suffer the same fate that she had gone through. So that's essentially my best take at her story, but I'm sure I'm not doing her story justice.
But part of the irony, and correct me if I'm mistaken, is that she tried to regulate her situation and was fraud by a immigration consultant. So she wasn't able to she put all her money in it. So she was not able to have a regular status in here. So this is a sad part of the story too.
This is happening to many migrants, those of us who are working in migrant worker centers. This is happening all the time. We're going to get a photo of Nell up soon. And just to say, yeah, she passed away last year, 54 years old, and she really should be with us. And it's really an example of healthcare delayed is healthcare denied. Okay, so thank you so much to our panel, Marie, Martha, and Wai. Short coffee break, and then we're back.